Hey everybody, welcome back. In today's video, we're going to talk about the consequences of a chronically high blood pressure on the heart, and we'll talk about how does the heart actually adapt to this chronically high blood pressure to function semi-normally. Now, if you guys like the video, if you truly learn, if you enjoy it, please consider liking, consider subscribing, and maybe leaving a comment. Now, without further ado, let's get into it. So, when we talk about the stroke volume, it's or really when we talk about high blood pressure in the heart, you have to know a couple of concepts such as stroke volume. And you guys should know already that the stroke volume refers to the amount of blood that I actually push out of the heart within one cardiac cycle. And the stroke volume is really affected by three main things. The first of which is going to be the preload, okay? And if you guys remember from the cardiac output regulation video, I mentioned that preload refers to the extent to which the heart is being filled, and more specifically, the extent to which the ventricles are being filled during diastole. So if the ventricles are being filled a lot, we say that there is going to be a high preload, okay? All right. Now, the other thing that determines stroke volume is contractility of the heart. And again, we're specifically talking about the contractility of the ventricles here. And the final thing is going to be afterload, okay? Now, again, contractility, you guys probably know what I'm referring to. I'm referring to how forcefully is the cardiomyocytes contracting, okay? How powerfully. And again, if they contract very powerfully, then we have high contractility. With the afterload, a lot of people may be confused by this. Afterload, and listen carefully here, is referring to the pressure that the heart has to overcome in order to open the semilunar valves, and the pulmonary semilunar valves and the aortic semilunar valves, both of them, to push blood out of the heart. Okay, so one more time, it is the pressure that the heart has to overcome in order to be able to eject blood out of the ventricles. Okay, and we'll get into this in way more detail in just a second. But with that kind of basic understanding, we have to understand how does the preload, the contractility, and the afterload affect the stroke volume. So we know they're definitely affecting it, but how are they affecting it? Okay, and what is affecting these guys to be able to affect the stroke volume? So let's start out with the preload first. We said that the preload is the extent to which the ventricles are being filled during diastole. So it can definitely be determined by the end diastolic volume, okay? If the end diastolic volume is high, we can conclude that we actually filled the ventricles a lot, and thus our preload is high, okay? But what determines the end diastolic volume? Well, the end diastolic volume, you guys know that it can be affected by venous return. Okay. But what affects the venous return, guys? Now, many things can affect venous return. One of the main things is going to be sympathetic nervous system activity. Okay, you guys know that here's a vein. Okay, veins, just like your arterioles, they also have those special receptors, those alpha-1 adrenergic receptors on them that can bind norepinephrine, and that will cause venoconstriction, not vasoconstriction, venoconstriction. Okay, because they're veins, but that would actually cause an increase in blood flow back to the heart, aka increasing venous return. There are other things that contribute to venous return. For example, the respiratory pump, the skeletal muscle pump, the cardiac suction effect. But we will have separate videos talking about venous return. Just understand for now that if I increase the venous return back to the heart, I'm going to increase the end diastolic volume, and I'm going to increase the preload. What happens if I increase my preload? What is the relationship between preload and stroke volume? Is it direct? Is it indirect? What's going on? Well, I'll tell you right now, guys, it is a direct relationship. If I increase the preload, I'm increasing my stroke volume. Okay? All right, on to the next one. Talking about contractility. Contractility, I'm sure you guys are screaming this at me, is affected by the sympathetic nervous system activity. If you guys remember, we said that we can activate the sympathetic nervous system. It will increase the influx of calcium into these cardiac myocytes via the L-type calcium channels, increasing calcium-induced calcium release from the SR and filling all of the actin and myosins to cause a very forceful, powerful contraction. that's what the sympathetic nervous system activity was doing, right? That was the Frank Starling law. It was allowing that to happen. Actually, sorry, the Frank Starling law was occurring because of the high EDV. The sympathetic nervous system activity is just increasing calcium and increasing contractility there. Okay. Now, another question that I will get asked a lot is, well, how is the sympathetic nervous system activity, increasing in the first place? Well, let's take a very common example, the exercise pressor reflex. Okay, so if you guys have watched any of my exercise physiology videos, you will know that there are special, metabolites and mechanoreceptors that are located, all around the body. Okay, mainly in the skeletal muscle, and when they get activated, they will cause an activation of the sympathetic nervous system activity. And when this guy's activated, he will go and increase contractility in the heart. Okay, so what is the relationship between contractility and stroke volume? Well, if you increase the contractility, you will increase the stroke volume. Okay, so it is a direct relationship. All right, now finally we're going to talk about afterload. And again, this is the difficult one for a lot of people. But again, afterload just refers to the ability of the heart to overcome the pressure that it needs to open the semilunar valves and push blood out. Okay, and again, I'll give a visual example of this later, just so it really makes sense to you guys. But when we talk about afterload, it's mainly going to be affected by a high blood pressure. Wait a minute, isn't the topic of this video high blood pressure? Yes, it is. So that's why we're talking about all this stuff, okay? Trust me, this will all make sense. Now, you can have high blood pressure for a number of reasons, okay? And I mean a number of reasons. So one of the physiological reasons could be an increase in your total peripheral resistance. So we'll have a video talking about total peripheral resistance. In fact, that'll be the next video. But just a brief intro, the total peripheral resistance is basically just talking about how much resistance are your vasculature, your peripheral vasculature, offering to blood flow. Okay, if there is a high resistance to blood flow, what that's going to do is it's going to increase your blood pressure. Okay, and this is all coming from the mean arterial pressure equation, right? So you guys know that your mean arterial pressure equals to your cardiac output times total peripheral resistance. And you know that if I increase the total peripheral resistance, I'm increasing the mean arterial pressure. Okay, so that's the relationship that we're drawing there. Now, how can you increase your total peripheral resistance? Well, this can actually occur for many reasons, one of them being, for example, vasoconstriction. That is a big driver. Vasoconstricting the arterioles can increase total peripheral resistance. What are some other things contributing to high blood pressure? You know, some diseases like atherosclerosis. Okay, atherosclerosis, if you guys don't know, let's say here is an artery. Okay, atherosclerosis is when this giant kind of fatty plaque develops on the artery wall, and it is actually impeding blood flow. So look, the blood beforehand was normally able to pass through the lumen, but now with this plaque here, only a little bit of that blood can pass through, and majority of it is kind of just occluding here, okay? If the blood is occluding here, you know what's going to happen? It's going to start increasing, all right, the blood pressure, the mean arterial pressure upstream of this plaque, right? And that's not what you want. That's not really good, okay? So this atherosclerosis can definitely contribute, and it can be fatal depending on where it is. And another physiological thing, I guess you can call it physiological, is aging. Okay, you guys know with aging, for example, your aorta. Okay, your aorta being a large elastic vessel. Okay, your aorta starts to become super stiff as you age, and that's because we don't synthesize as much elastin anymore, and we start depositing a lot of collagen into this aorta, right? And what ends up happening is this guy becomes super stiff, non-distensible. It can't go through the Windkessel effect, and it can't distend and absorb that pressure gradient from the left ventricle, and guess what? It'll become kind of like a steel pipe, and because of that, that will increase the mean arterial pressure a lot, actually. Okay, so you'll see this a lot. We talked about this in a previous video with aging increasing the blood pressure. But now you guys know that if I increase the blood pressure, I will increase my afterload. Okay, now what is the relationship between the afterload and the stroke volume? It's inverse, guys. If I increase my afterload by having a high blood pressure, I would actually decrease my stroke volume. Okay? Remember this relationship. This is really important. So a high blood pressure can increase the afterload of the heart, which will drop the stroke volume. Okay? All right. Now, knowing this, keeping this in mind, let's go ahead and talk about the consequences of high mean arterial pressure. And I say part one because there's two parts to this. So the first part is going to be just us going through a normal heart, just to give you guys a reminder of what we're actually talking about. So I took these diagrams, right? I made them from the Wigger's diagram. I just took the liberty of modifying that one for you guys. To give you a brief reminder, here's how a normal heart should be working, right? Here's the left ventricular pressure in red, and here's the aortic pressure in this purple color. These yellow boxes here are going to be your isovolumetric phases. So this one is the isovolumetric systole, this one is the isovolumetric diastole phase, okay? And here is the ejection phase in the middle. So you guys know that during diastole, my aortic pressure is approximately 80 millimeters of mercury, and you can see that right there. You guys know that during isovolumetric systole, the entire point of it is for me to generate enough pressure inside of the heart to go from approximately 0 millimeters of mercury to 80 millimeters of mercury to then be able to open up the semilunar valves and push blood out into the aorta, right? You guys know that. That's a refresher from cardiac cycle video, from the Wigger's diagram video. If you need a refresher, go back and watch those. Now, after we do that, we know that the pressure continues to rise to about 120 in both of these guys, and then it goes back down because the heart is relaxing and the aorta is going through the Wynn-Kessel effect. There will be the dicrotic notch indicating the closure of the semilunar valve, right, causing a slight increase in pressure there and then going back to normal. Okay? How can we show this graphically? Well, good question. Let's say here's diastole and here's systole. Okay? We said that the pressure in the aorta is about 80 millimeters of mercury at diastole. And you guys know, again, during diastole, what's happening? Blood is coming in to the ventricles, okay, and filling all around the place. Look at that. And we said that the pressure during diastole will be approximately 0 millimeters of mercury, okay? I know, I said something different in the Wigger's diagram, but for the sake of this video, for the sake of understanding and teaching, let's just say it's about 0 millimeters of mercury, okay? But you guys are smarter than that. You know that it might be higher. Now, in the systolic phase, right, what happens? You open up these semilunar valves right here, okay? The atrioventricular valves are closed, right? You're pushing out blood right here. You see that? You're pushing out blood. And what happens? The pressure inside of the aorta will become 120 millimeters of mercury, again, approximately. And we know that the pressure from systole was going from 0 all the way to 120 millimeters of mercury, right? And, if we were to measure the end systolic volume and the end diastolic volume, right, on average, the stroke volume for this guy, this normal person, normal individual, no high blood pressure, should be 75 milliliters, okay? That should be the normal stroke volume for this guy. But now, let's say we're going to now look at a high blood pressure individual, guys, okay? And this will have two phases, so I'm going to cover it in these two graphs right here. Both of these guys are high blood pressure. Something I got to explain before we go into these is that when you have high blood pressure, right, if you look at it, you will increase the afterload and you will decrease the stroke volume. But this only occurs briefly before the heart adapts. Because think about it. If the stroke volume is down, what does that mean? That means I'm actually pumping less blood out of the heart per cardiac cycle. That can't be good, right? That could probably lead to death eventually. So the heart has to adapt somehow. And when it does adapt, that'll have some consequences. But there is that brief period, this brief moment in time where when you increase the high blood pressure, the heart is kind of shocked. It's like, whoa, where did this high blood pressure come from? I'm not ready for this yet. So its stroke volume drops. It is not ready for this high blood pressure. It hasn't compensated for that high blood pressure. We call that phase, that little brief period when the heart hasn't adapted to that high blood pressure, we say that is the precompensation phase, okay? And when the heart does compensate, we say that that is the compensation phase. Now, briefly, what do I mean when I say the heart compensates? Well, the heart has to increase its stroke volume again because, remember, a high blood pressure increases the afterload, which decreases the stroke volume. So the heart has to compensate and adapt and increase the stroke volume. How does it do that? Well, you guessed it. It'll activate the sympathetic nervous system to increase its contractility to counteract the effects of the actual high afterload. But this will have some consequences, as we shall see. Let's dig into the graphs. So now that you know what the precompensation is, and again, it is just the portion in time where you have high blood pressure, but the heart hasn't increased its contractility to increase the stroke volume. In fact, the stroke volume has dropped, and we will see that right now. So what do you notice between this graph and this graph? I'll tell you what I notice. Immediately, the first thing that pops out to me is the isovolumetric phases. They are much thicker over here in this precompensation phase, much thicker, and that has a reason to it. Another thing I notice is that the aortic pressure no longer starts at 80 millimeters of mercury at diastole, but it starts somewhere around 110, 120. And it actually rises to, I don't know, let's say 150 rather than rising to 120 during systole. Okay, that's very concerning. That means that I have an extremely high afterload, right? Because look, over here in the normal guy, the heart had to go from 0 millimeters of mercury all the way up to 80 millimeters of mercury to open up the semilunar valves. Over here, the heart has to go from 0 millimeters of mercury to 120 millimeters of mercury to even be able to open up the semilunar valves. What did I tell you is the definition of afterload? It is the amount of pressure the heart has to overcome to be able to open up the semilunar valves and push blood out of the heart. If there is a high blood pressure, the heart has to work harder to do that. But remember, the heart can't do that right now because it's in a precompensation phase. So what does it do? Well, it does the only thing it can do. Remember what I told you about the isovolumetric phase. I told you that this isovolumetric phase, all it is that you are literally just sitting here in this phase, contracting the heart so you can build enough pressure to open up the valve. And in this scenario when you have high blood pressure, high afterload, and you haven't adapted yet, you haven't compensated yet, all the heart can do is just sit in this phase for a longer period of time to try and reach this 120 millimeters of mercury. Look at this. It is sitting here for a long period of time. Like imagine there's an x-axis here in time, in seconds, or milliseconds, whatever you want. You would see that this guy from here to here is taking much longer than here to here. So to summarize, the heart, because of the high blood pressure and because it has not compensated yet for that high blood pressure, it is sitting in the isovolumetric phase for a longer period of time to try and match this pressure. And it will eventually do that, but it'll just take it a long time to match this pressure here. Okay? And once it finally matches this pressure, it can then push out blood. But now there's another problem. What is the problem here? Look at the ejection phase. You see the ejection phase? It was so long initially, but now it's super short. Why is it super short? It's super short, guys, because the isovolumetric phases are long. Okay? Now, a lot of people will ask me, they're like, okay, Kian, it makes sense. The ejection phase is smaller because the isovolumetric phases are taking up all the space. And it also makes sense that the isovolumetric systole phase has to be long because, well, the heart has to spend a lot of time in here to generate pressure in this precompensation phase. But why the heck is the isovolumetric diastole phase also thick? Remember, you generated all of this pressure, right? You have to also dissipate all that pressure. So the same amount of time that it took you to build up that pressure, it will take the exact same amount of time to dissipate that pressure, okay, to lower that pressure. That's exactly why this is also just as thick as this guy. And that's why the ejection phase is much shorter. So when I tell you that I am actually lowering stroke volume in these guys, it is because the ejection phase, guys, is getting so much smaller because these isovolumetric phases are getting longer. Okay? Let's show that visually. Okay? So Now let's say instead of again starting at 80 millimeters of mercury and diastole, I started 120 millimeters of mercury. And again, you guys know that during diastole, the ventricles are getting filled, right? There it is. And the pressure inside of the ventricles should be, again, approximately about 0 millimeters of mercury, right? And during systole, now this is the interesting part. You open up the semilunar valves, you close the atrioventricular valves. The pressure inside of the ventricle is rising from 0 to 120, okay? 0 to 120. And boom, boom, boom. And the pressure inside of the aorta, right, as we're pushing blood into it, is elevating from 110 to, let's just say, about 150 millimeters of mercury. That's insane, guys. That's insane, okay? But notice the stroke volume, if we were to calculate it, right, it would actually drop to, let's say, about 40 milliliters, okay? It would drop to 40 milliliters. And again, these are hypothetical numbers just to get the point across to you. But this would happen in the precompensation phase when we are initially exposed to this high blood pressure before the heart has had any chance to adapt. It will drop its stroke volume, just like we said it would. High after load decreases the stroke volume. But the heart can compensate. The heart can compensate. How will it do that? Look at the compensation. What is the difference that you see in these graphs between this guy and this guy? I'll tell you the difference I see again. The first difference I see is the isovolumetric again. It is so much smaller. In fact, guys, it is even smaller than the normal guy, than the normal scenario. That is peculiar. That is peculiar. How is the heart doing this? And it also seems to me that the ejection phase has increased way more than the precompensation phase and a lot way more than the normal phase, okay, than the normal guy. This will have some implications. So let's take a look at this. How does the heart actually do this? So again, let's start out with that same 110 millimeters of mercury. And let's say again, the pressure in here was 0 millimeters of mercury. And again, we know that during diastole, blood is actually coming in, filling up these ventricles, okay? And then when we move on to the systole phase, guys, what happens? In the systole, we close the atrioventricular valves, we open up the semilunar valves, and you guys know that we were building up pressure inside of the ventricle. But now, instead of building pressure from 0 to 120, we're going to do something different. We're going to have, and let's show it in this color, we're going to have sympathetic innervation, right? Look at this. We're going to have sympathetic innervation coming to the heart. Look at it. Boom. We're going to have sympathetic innervation to the heart, okay? Releasing norepinephrine on the cardiac myocytes, increasing the contractility by bringing in calcium, causing calcium-induced calcium release, right? Increasing the contractility. If I increase the contractility on these guys, what's going to happen? Well, I'm not going to build up pressure from 0 to 120 now. I'm going to build up my pressure from, let's just say, for the sake of laughs, 0 to 150 millimeters of mercury, okay? And now would you look at it, I'm actually ejecting a lot of blood out into this aorta, okay? With the pressure still being, again, around that 150, maybe 160 millimeters of mercury, something like that, okay? Awesome. As we're ejecting blood into it, the pressure will, rise from that 110 into the 150, okay? But do you notice what happened here? This is the key part. Do you notice what happened? With the sympathetic innervation, the heart was able to overcome this high blood pressure much faster and eject blood out, which is what you want, by the way. Because, like I said, a low stroke volume can be super detrimental to the rest of the body because it's not getting the blood it needs, okay? But the heart compensated for this by increasing the stroke volume. How? By activating the sympathetic nervous system and increasing the contractility, increasing the stroke volume to counteract the effects of the high afterload, right? Spend less time in the isovolumetric systole phase and reach the blood pressure that it needs to not the blood pressure, reach the pressure that it needs to open up these semilunar valves much faster. But this comes at a cost, and we'll take a look at that in a second. But again, hopefully you guys understand why we now have these shortened times for these isovolumetric phases. It is just because the heart compensated with the high stroke volume, and it was able to reach the pressure needed to open up these semilunar valves. Okay, so what is the consequence of this? What is the consequence of this? You know, the heart itself, guys, I talked about this in the cardiac cycle video, but the heart itself gets its blood mainly in the diastolic phase. So you guys remember we had the cardiac cycle, right? And the cardiac cycle time could have been divided into both the systole phase and the diastole phase, right? And if you guys remember, it was going to be about 0.3 seconds systole and 0.5 seconds diastole, okay? And we said that during diastole, that's where we're going to actually get majority of the blood. And that's why you want to keep a higher ratio of diastolic time to systolic time, because the heart needs its own blood to function properly. However, what do you notice with the timing after the compensation? If you notice something, the heart spends a lot of time in the systole phase. And you might be thinking, well, wait a minute, Kian, what the hell are you talking about? I'll tell you. Look, this is systole, right? From here to here, the ejection phase. Yep, it is systole. This is also systole. Notice how much bigger this guy got. Notice how much bigger this guy got after the heart compensated. The heart is spending much more time in the systolic phase after it compensates for this chronically high blood pressure. And this is key, guys. It's chronically high blood pressure, which means the heart has to keep compensating like this. It has to stay like this in order to maintain sufficient stroke volume to the rest of the body. Okay? And this is going to have effects for the rest of the body, specifically the heart. Okay? The heart mainly. Because the heart is spending more time in systole, that is going to change the ratio between these guys. That means I'm going to spend more time here and less time here. And if I spend less time in here, where I gain majority of the heart's blood, that can actually lead to myocardial ischemia, meaning low blood flow to the heart itself. And if the heart has low blood flow, that can lead to a heart attack. Okay? And we'll talk about this soon. But just to finish up here, we mentioned that in a normal guy, the stroke volume was 75 mLs. We said that in the pre-compensation phase, after we increase our blood pressure, the heart becomes super shocked. It hasn't compensated yet for it. It spends more time in the isovolumetric systole, lowering the ejection phase, thus leading to a smaller stroke volume of 40 milliliters. But then after we go through that compensation phase where we activate the sympathetic nervous system, we can actually raise our stroke volume back up to about 70 milliliters, okay? And so you can see I rescued the stroke volume, but at what cost? At an increased workload of the heart. That was the cost, okay? And we'll see that this chronic increased workload of the heart is not actually doing us any favor, okay? The heart is one muscle you do not want to train to failure. And just to give you guys a visual demonstration of this, imagine here is a vein, okay? And here is another vein, all right? Right there, let's do it like that. That's fine. And here is the muscle, okay? Boom, boom, and boom, boom. So guys, imagine this is the heart muscle, okay? Here's the heart muscle, and in blue is the vessel that is feeding them, okay? So here's blood flow coming to this, right? And the blood will actually, the nutrients, the gases and all that stuff, they will diffuse into these muscles pretty fine, okay? This is during diastole. During diastole, these vessels are open. The muscles are not contracting. They are relaxed, these vessels are open, and everyone's happy. They're getting their oxygen supply and all that stuff. But something crazy happens during systole. So let's look at systole. During systole, what ends up occurring is that here's your muscles, here's the cardiac muscles, okay? Again, these are cardiac muscles. We're talking about the heart. These guys will now become activated during systole and they'll start contracting. And when they start contracting, right, you guys know that these blood vessels, they're actually kind of embedded in between each of these muscle cells. These muscle cells will contract so forcefully that it'll cause these vessels to collapse, okay? Temporarily, of course. It'll cause temporarily collapsion of these actual vessels, meaning what? Meaning that no blood can actually go in here, okay? None or little blood can actually come in here. And it'll just kind of accumulate in here until we go back to the diastolic phase where what happens? These blood vessels open up again and we can, nourish the heart or perfuse the heart, if you will, with a lot of blood, okay? But this is why I say that it's dangerous for the heart to spend a lot of time in systole as opposed to diastole, because in systole, it's not getting a lot of blood, the heart. And that can lead to ischemia, which can then lead to death of the heart muscle. So here's the second consequences that we're going to talk about right now, right? We're going to draw a little flow chart discussing the consequences that we have been talking about. So we know that in order to compensate, we have to increase what? The sympathetic nervous system activity, which will then lead to an increased contractility of the heart. We know exactly how that's done. We talked about that in the cardiac output regulation video. This will lead to an increase in stroke volume, which will counteract the drop in stroke volume that was experienced by the high afterload. This, in turn, will increase the energy demand, or the ATP demand, if you will, from the cardiac myocytes, right? Because remember, they're increasing the contractility, right? But that's not free. They're not working for free. They're working from energy, right? And if I increase the contractility, and this has to occur chronically to maintain blood flow to the rest of the body, they're going to need more ATP. So they're increasing their ATP demand, okay, from myocytes. Okay, cool. What is that going to do? I'll tell you what that's going to do, guys. That is going to lead to an increased systolic to diastolic time ratio. And that's not what you want. You don't want to spend more time in systole than diastole. And we just gave the reason why. But let's say you do that. What does that do? Well, it's exaggerated with this red color. If you do that, that will actually lead to a lower oxygen supply, okay, to these actual muscles, right? Because I'm spending more time in systole, delivering less blood, and that's going to lower the oxygen supply. If you lower the oxygen supply, you know what that does? That is going to lower the ATP actually being delivered into these guys. So lowered ATP production, right? Because you guys know from cellular respiration, we require oxygen to make ATP, okay? From, aerobic respiration through the electron transport chain and all that jazz. And in fact, if you guys know, if you've watched my muscle video, that if you don't have ATP, that can actually cause rigor mortis to occur in these muscle cells. And so they can actually end up relaxing. That's another thing. And another thing that this high systolic to diastolic ratio can do, it can cause, as I've been saying this whole video, it can cause myocardial ischemia, right? Which just means low blood flow. Do not get this confused with a myocardial infarction, which is a heart attack. That is an MI, that's a myocardial infarction. An infarction is a prolonged ischemia, all right, that has led to the death of the tissue. But an ischemia just refers to low blood flow, but a myocardial infarction can occur from a prolonged ischemia, which leads to tissue death. Now, if the myocardial infarction is severe enough, it can cause death of the individual. If it is not severe, it might end up leading to congestive heart failure, which is usually due to poor left ventricular output, okay? And again, if this is severe enough, it can lead to death. And another thing that this congestive heart failure can possibly lead to is pulmonary edema, okay? Pulmonary edema, and it's really just because this congestive heart failure refers to a low stroke volume, okay? The heart becomes so overworked that it eventually just cannot keep up with the increased demand because of the high blood pressure, right? And it's because of this pathway that we just talked about, right? Low oxygen supply, low ATP, low blood flow to the heart, right? It can't keep up with the demand. It can cause death of the tissue. And when the tissue dies, there's not enough contractile tissue, right? And if there's not enough contractile tissue, you can't keep up with the stroke volume, and that can cause congestive heart failure. Now, if there's heart failure, that means the heart is not pumping blood out to the rest of the body, and the blood is kind of just accumulating within the ventricle after each cardiac cycle. Eventually, that blood in the left ventricle can leak out through the pulmonary veins back to the actual pulmonary circulation, causing pulmonary edema, which is not good. Okay? So again, you do not want this stuff to happen. All right. Now, guys, that is going to finish it with the consequences of a high blood pressure on the heart. If you learned something, if you truly enjoyed it, please, again, consider liking, consider subscribing. I always put out a lot of content on a lot of biology-related stuff. If you want specific content you want to see from me, leave a like, leave a comment down below, and give me suggestions. But that's going to be it for this video. In the next video, we will talk about regulating blood flow, and we'll talk about microcirculation. So I will see you there.